There we go.
Okay, so I'm going to try to share my screen, and I do have some videos embedded. And I've never, let's see, share sound and optimize for video clip. All right. Oh no, it says to share your computer audio, please install the Zoom audio device. Please I've never shared an Zoom video on this computer. Please restart your audio sharing application such as the media player after install to continue sharing computer sound.
Uh-oh.
You know what this is?
I don't, but if you send the videos to me, I can play them.
Let me send you this presentation, Katrin.
Okay.
Just a minute.
In the meantime, how is everyone? Anyone?
Sorry for the delay, everyone.
I'm peachy.
Me too. I'm the same way.
Doing all right.
Sorry, everybody. Okay, Katrin, I'm just resending this to you.
Okay.
Did you get it?
My email?
Yeah.
Not yet.
PowerPoint's showing up on the video.
What?
The PowerPoint's showing up, but we still need the
PowerPoint is showing up.
Yeah.
You can see this.
Yep.
Did you get the PowerPoint, Katrin? Let me try one more time. Sorry for the delay, everybody. Tell me if you got it now.
Not yet.
Okay, well, you'll get it. So let's start, and I do have 4 embedded videos, and worst case scenario, I can send this presentation, I can post this presentation online, and you can watch the videos yourself. Did you get it, Katrin?
I got it.
Okay, great. So I'll key you when it's time to play the videos. I don't know why it's not letting me play the videos.
Okay.
So let's, okay. So this presentation is about mixed episodes and rapid cycling. And most of you probably know what these are, but I'm going to go over a quick introduction of what each of these things are. And then we'll get into some details. So what I talked about last time, the last time I presented, was the DSM-5 specifiers for bipolar disorder. So the 5th edition of the DSM uses specifiers in the diagnosis of mood disorders. So for example, a specifier may be bipolar disorder, comma, rapid cycling, comma, severe, comma, whatever, atypical, peripartum onset, seasonal pattern, etc. So there's 2 categories of specifiers, those for defining the current or most recent episode, and those concerning the course of recurrent or repeating mood episodes. So the first category, which defines current or recent episode, includes mixed features, anxious distress, melancholic features, atypical features, psychotic features, and catatonic features. So you may have bipolar disorder, comma, psychotic features. And then the second category is defining the recurrent episodes, which includes rapid cycling, peripartum onset, and seasonal pattern. So for example, a common kind of bipolar diagnosis may be bipolar disorder, mixed features, seasonal pattern. So that means that you have bipolar disorder as a whole, with your most current episode being, I think I said mixed features, and you have a seasonal pattern, which means that maybe every spring you have a mixed features episode. There's also severity specifiers that are used to describe mania only. And so the purpose of these specifiers is to identify how much impairment a person experiences. So two of the most common specifiers, like I just said, are mixed features and rapid cycling. And that's what we'll be talking about today. So mixed episodes. The DSM-5 says mixed episodes with mania is if you are in a manic or hypomanic state with mixed features, you will have met the criteria for a recent manic or hypomanic episode, but also have experienced symptoms of depression. So how this looks like for me, I'll just tell you for me. Mixed episodes look like I'm really hypersexual, really manic, running all over the place, doing a lot of work, but also suicidal. So that might be an example of a mixed episode. Another example of a mixed episode could be feeling very, very sad and very depressed and crying all the time, but also having severe panic attacks and screaming and yelling, or maybe having anger episodes. That could be also an example of a mixed episode. So again, we're looking at a loss of interest or pleasure in the activities you usually enjoy, but maybe also being manic. So also, so maybe having these depression symptoms that I have listed on the slide, but also feeling enhanced exercise, enhanced activity, like a lot of work activity or goal-focused activity, risk-taking activities such as being hypersexual or shopping a lot or spending a lot of money or over-socializing, over-scheduling yourself. So if you have some of those symptoms of mania or hypomania mixed with feelings of sadness or emptiness or loss of that interest or pleasure, that will probably give you a mixed episode criteria. So the mixed episode with depression is where you have a primarily depressed state, but with features of mania, such as an elevated mood state, self-esteem or grandiosity, excessively talkative, racing thoughts, increased energy. So kind of everything I just talked about, unwarranted wish-taking. So again, financial, physical, sexual, etc. This is going to look like someone who's predominantly depressed, but maybe is talking a lot, really pressured speech, or someone who's predominantly depressed but works 20 hours a day. That's where you're going to get the mixed episode with depression. So the DSM says that bipolar disorder with mixed features means that you have both manic and hypomanic symptoms and depressive symptoms in the same mood episode rather than one or the other. So if you recall, when you have a typical mood episode, you're either mostly manic or hypomanic or mostly depressed, most of the time, most every day of the week. To be diagnosed with the mixed episode specifier, whether defined as manic, hypomanic, or depressive, you must meet all the criteria for that episode and have at least 3 symptoms that belong to the opposite type. So I just described to you that my mixed episodes look like feeling suicidal, feeling hopeless, feeling desperate, but also being hypersexual, spending a lot of money, being excessively goal-oriented, working 18, 20 hours a day. So I meet 3 criteria for the manic and all the criteria for depressive episodes. So that's what a mixed episode looks like. Oops, sorry. Let me go, I went too fast. So, Catherine, do you know how to get rid of these people on the side? I got
no.
it. So we found that people with about 40% of people with bipolar disorder will experience a mixed episode at least once during the course of their illness. So it's very, very common to have a mixed episode. Again, almost 50% of people with bipolar disorder will have a mixed episode. And so, for example, a person may have maybe in a hyperactive state, which is a symptom of mania, who also has feelings of deep guilt or remorse, which would be a symptom of depression. Or you may be crying uncontrollably, which is a symptom of depression, but be fixated on performing a task that has to be done now, which is a symptom of mania. I would really recommend that you go to this link here, and it will be posted when Catherine posts the video. But diagnosing a mixed episode in bipolar disorder by Very Well Mind is a really good overview of mixed episodes. Why isn't it letting me? Why isn't it letting me move? Okay, so this is the first video, Catherine, if you want to play it.
Okay, 1 second. Just give me 1 second, guys. I'm sorry.
Yeah, I don't know why my computer won't let me play these videos.
There we go. Okay.
And if you can't get it, Catherine, we can just,
Can you see my screen?
yes.
Okay.
Hey everybody, today I'm going to talk
Can
about
you hear it?
mixed episodes in bipolar disorder. What causes them?
Oh,
Hey everybody, today I'm going to talk about mixed episodes in bipolar disorder. What causes them, how they can feel, why they're dangerous, and of course, what we can do to better manage them. And thank you to Equilibria Premium CBD Company for sponsoring this video. Let's get into mixed episodes themselves. And while we all have heard people talk about the highs of mania or hypomania and the lows of bipolar depression, a mixed episode happens when both of these symptoms occur at the same time, meaning that we feel impulsive, having flights of ideas, not wanting to sleep, but are also irritable, physically exhausted, and hopeless about our future. And it's diagnosed as having met the criteria for a manic or hypomanic episode, while also having at least 3 depressive symptoms. And I know it's hard to comprehend how someone could feel both depressed and manic at the same time, since we often think of people swinging, from one extreme to the other. But mixed episodes are extremely common. About 40% of those with bipolar disorder will have one, and they are extremely uncomfortable. Many of my patients in the hospital and even in my private practice have described it as having so much energy, but feeling terrible about it. One patient said she wished she could just tear her skin off. It was so unbearable because the manic symptoms are so impulsive and erratic, but we also feel depressed or hopeless. And this state can be very dangerous. When we feel that low and have the energy to do something about it, suicide attempts go up, which is why any mental health professional will be watching us closely if they think that we are in the midst of a mixed episode. It can also be dangerous to our bank account and our relationships because we can impulsively spend, have casual sexual encounters, and even look to argue or fight with those that we love, which is why it's really important that we let our treatment team know that what we are experiencing is a mixed episode so that they can help us manage the symptoms before anything bad happens. On average, just so you know, these episodes last for at least a week, but they can last 2 weeks or longer. So the sooner we speak up and reach out, the better. While I don't have bipolar disorder, you all know that I do struggle with symptoms of anxiety and pain in my back and shoulders from Lord knows what, working out, stress, getting older, maybe all those things. But Equilibria's Daily Drops, which offers
Sorry about this ad.
full spectrum CBD, have helped me fall asleep more quickly without having as
Can
many
you
of
get
those
spin
worry
through
about
this, Catherine?
up at night. Treated bipolar disorder have a brain that has less gray matter than people who don't have bipolar disorder. And gray matter is important because it helps us process information, thoughts, and feelings. It also helps process and direct information from one part of the body to the next. Since it's made up of neuronal cells, it's responsible for receiving sensory input from the world around us and then telling our muscles what they need to do in response. The gray matter in our brain builds up from birth and is fully developed when we are in our 20s. And overall, it makes up about 40% of our brain. The 60% left is made up of what is called white matter. Having less gray matter can cause us to be more impulsive. It can make it more difficult for us to process our feelings and struggle with coordination and movement. And it can even affect our memory, which may explain why those of us with bipolar disorder can, when we're in a manic or hypomanic state, be really impulsive, not remember portions of the episode, and make careless choices that we may later regret. A 2017 study from the University of Southern California also found that when treated with lithium, which, if you didn't know, is a treatment for bipolar disorder, although I know it's not everyone's favorite, but when treated, the gray matter was not found to be as thin as those who did not receive any treatment. Therefore, getting our bipolar disorder properly cared for could protect our brain a bit. Bipolar disorder is also found to be connected to variations in the levels of dopamine, norepinephrine, and serotonin in our brain. Now, dopamine is responsible for us feeling pleasure or reward in our life. Norepinephrine is in charge of our sleep-wake cycle, hunger fullness cues, sex drive, impulsivity, learning and memory, so just a lot of stuff. And serotonin is otherwise known as the natural mood stabilizer since it helps regulate our mood. It is believed that bipolar disorder causes these three brain chemicals to fluctuate, which could account for all of the symptoms, such as decreased need for sleep, feeling active and excited one week and depressed the next, just to name a couple of things, which moves us into ways that we can better manage our mixed episodes. Now, first up is therapy, and more specifically CBT, or cognitive behavioral therapy. Now, I've worked with many people who have bipolar disorder, and being a detective about our symptoms is key to us preventing any mixed episodes from happening or for lasting very long. It can be helpful to recognize when we start to have more racing thoughts or not needing as much sleep, or maybe feeling extra irritable or unmotivated. Knowing that as early as possible gives us time to use our tools and even call our psychiatrist to see if a medication increase or change may be helpful. It can also help to create a healthy daily routine, meaning that we eat regularly, drink enough water, and get enough sleep. I know that sort of thing sounds obvious, but it's so often ignored. When we have bipolar disorder, having a routine can help us manage our symptoms better and more quickly notice when we are feeling off. It can also help to notice our self-talk and work to make it more loving and compassionate. Not only will this help keep us motivated and recognize when our depression is creeping back in, but can also help us better problem solve. When we think more clearly, we're able to see possible solutions more easily. And that will not only help us in our relationships, but also overcome any side effects of our mental illness, like dealing with large credit card bills. Our ability to more easily problem solve can help us keep our stress levels low and prevent a possible relapse. While therapy can help us better manage the symptoms, medication is an important aspect of our treatment as well. Most research shows having a mood stabilizer or atypical antipsychotic on board will help lessen our symptoms of bipolar disorder. I've had patients who are on one or multiple medications to alleviate their symptoms, so know that another person's experience is just that. It's theirs, and your situation could be vastly different. And obviously, I am not a doctor, so please reach out to a psychiatrist or other physician to be properly diagnosed and treated. And make sure you ask them any questions you have about medication, like possible side effects you need to look out for, or how long it can take before you feel the effects of it, and any other concerns that you may have. As a side note, I just think it's important to mention that it is common for those of us with bipolar disorder to reach out for help when we feel depressed, and then be misdiagnosed as having major depressive disorder, which can lead to us then being placed on an SSRI or an SNRI, otherwise known as an antidepressant. And because those medications are activating to our system, we can be pushed artificially into a manic or hypomanic episode. So if you have experienced any symptoms of mania or hypomania, like maybe not needing as much sleep for a week or more, or feeling like you have so many good ideas, you can't even put them into place fast enough, or maybe you feel really irritable at everyone around you for no identifiable reason. If you feel any of those, please let your prescribing doctor know so that we can avoid any potential manic or hypomanic episode due to a medication. And that's all I have for you today. I hope you found that helpful. I'm always
Okay, you
happy
can
to
turn that
dive
off,
into
Catherine.
other mental illnesses and their symptoms and how we.
There we go.
Okay, let's
Your turn.
get back. Okay, so she mentioned suicide briefly, but I really think she should have spent a lot more time on this because suicide in mixed episodes is a huge risk. And the reason it's such a huge risk is because you have the depressive component in a mixed state where you're feeling maybe suicidal, maybe you're feeling desperate, maybe you're feeling sad, but you have an extra energy or extra irritability. And the risk of suicide goes up dramatically in mixed episodes. So just having a depressive episode has a lower risk of suicide, and just having a manic or hypomanic episode has a lower risk of suicide. But people in a history of mixed states could have up to 71% increased risk for suicidal behavior. So this is really critical. The bipolar disorders a journal, which is the leading journal for bipolar disorder research, found that the depressive component of mixed states with bipolar disorder was associated with a high risk for suicidal behavior. And the study authors concluded that the takeaway message from this research is that much of the suicide risk related to having a history of mixed states is not a product of the mixed state itself, but rather can be attributed to a depression predominant course of illness. Catherine, I have another video for you.
Okay.
And this is a lived experience video, unlike that last one, which was of a therapist. This is someone who actually has bipolar mixed states, so I thought it would be a good example of someone who actually lived with mixed states.
Okay, let me pull it up.
And then I don't have the ability to do a survey on this, but I'd be interested to hear just from like a raise of hands or something, or Catherine, if you know how to do a poll, how many people here have experienced mixed states? I'd be interested to see if our population is similar to what the research shows.
I don't know how to do a poll or anything like that.
Okay. Go ahead.
Okay.
Hi, this is Sally, and today I'm going to talk to you about mixed states or mixed episodes. Now, I know that mixed states are now referred to as either mania with mixed features or depression with mixed features. However, I still call them mixed states because to me they are completely unlike depression. They're completely unlike hypomania or mania. They are a complete fourth state to be in. When I was younger, I didn't experience mixed state. No, that was when I was, in a teenager or to some extent a young adult. My bipolar could have been described as pretty clean cut in that I only experienced depressive episodes or euphoric mania. But when I was 22, I experienced my first mixed episode. That was right before I was diagnosed with bipolar disorder. So I was misdiagnosed with depression, and I was put on an antidepressant after trialing a lot of antidepressants that didn't work. So this antidepressant did nothing for my depressed mood. I remained suicidal, but it replaced the lethargy and the fatigue of the depression with this relentless agitation and this restless energy that couldn't be burned up. And I was really irritable. I was impulsive. I had racing thoughts, but instead of being wonderful manic racing thoughts, they were depressed racing thoughts that revolved around death and decay. And I couldn't sleep. And that was the worst part, because I couldn't sleep to escape the prison my body and mind had become. That's what it really felt like. During that time, I was diagnosed with bipolar disorder and I was put in hospital because of that mixed state. I usually experience mixed states when I am transitioning from mania into depression, or if I'm put on certain class of antidepressants, that can put me into a mixed state as well. When I experience the mixed state, I have the combination of the manic energy and the manic speed coupled with the depression, so the depressed mood and so forth. And when you feel really agitated and really restless, makes you feel really frustrated and angry as well. And it gets to the point where this frustration and anger physically hurts. And this is a part of a mixed state as well. One hospitalization, I was in a mixed episode. And for a lot of that hospitalization, I was really frustrated and angry. And I remember I would just throw things around my hospital room because I had to physically get this frustration and anger out. So I'd throw things around my hospital room, I'd punch and I'd kick the doors, and I'd hit my head against the wall to make these racing thoughts stop. And the first time I did this, everybody was getting ready to contain me. But a nurse walked into my room and she just held me. And it was like a comforting hold. And she did what I couldn't do, which was stop my body from moving. And then whenever that happened after that first time, the nurses would just come in and hold me. And that's a really effective strategy for me to help me calm down. If I am experiencing this restless frustration, for people to just hold me until I calm down. Some strategies for mixed states are, well, it can be pretty hard to try and manage mixed states because the irritation is really, really strong and you're really, really impulsive. But some things that helped me are my mum will take me out on a drive. I'm really agitated, and I find that is quite meditative and it calms me down. Whenever I've been in hospital and I've been restless and agitated, mum would just come in and take me out on a drive so I could calm down. When I'm out in the community and I'm experiencing a mixed state, I find running is really good for anger and frustration, and walking is really good to help you sort of slow down and calm down. I also throw a tennis ball against one of our brick walls outside to help with the anger. And if I'm feeling as if I'm in a destructive type of mood, I will just tear paper until that passes. And most importantly is getting enough sleep, which I know can be quite difficult to try and do naturally if you're in a mixed state. So sometimes medication can help with that as well. But most importantly, mixed states don't last forever. They're cyclical in nature, just like our other bipolar mood swings, and they can be treated pretty quickly if they get the right and effective treatment early on into the mixed states. Thanks.
Thank you, Katrin. Okay, so before we move on to rapid cycling, I want to know if anyone has any questions. You can either post this in the chat or just start talking. If you have any questions that you would like to discuss about mixed states before we get into rapid cycling. And I can't see the chat box, so Katrin, if you can.
Okay, no questions yet. Why can't you see the chat box?
I don't know.
Press chat.
I can't see anything.
Okay,
Can you still see my screen?
no, I can see you.
Oh, I think something went wrong.
Does anyone have any questions so far on mixed episodes? Who has mixed episodes? I do.
I do. Do they ever go away or lessen does the severity ever get where it's manageable?
With medication, yes. But not if you're not medicated properly, I think it's very hard to manage mixed states without proper medication.
Okay.
I'm in a mixed state right now, so yeah.
I just
I'm
got
sorry
through
to-
6 weeks of it.
You have to be very careful when you're in a mixed episode.
Yeah.
So no more questions.
Okay, I'm having technical difficulty.
Okay.
Let's see. Okay. Somehow my screen got unshared. Okay. Can you see my screen?
Yep.
All right. Yeah, I have mixed dates too, and they're really they can be really awful. So rapid cycling is next, and we'd already talked about the DSM-5 specifier for rapid cycling. So rapid cycling is specifically defined as 4 or more episodes of either mania or depression in 1 year. And it can occur at any point during your bipolar disorder course and can come and go over many years. So it is not necessarily a permanent or indefinite pattern of episodes. So for example, it's very common for people to have rapid cycling at the beginning of their bipolar disorder, like when they're teenagers or young adults. And as they age, their rapid cycling calms down and they have a more normal course of bipolar disorder. It can also be in a minute where you would have a rapid cycling, let's say during your early 30s, it lasts for 3 or 4 years, then it goes away and it comes back again in your 50s. So that's really typical as well. And the key here is that in rapid cycling, a person with the disorder experiences 4 or more episodes of mania or depression in 1 year. So hypomania does not count. So if you have 4 or more episodes of hypomania in 1 year, that does not count as rapid cycling. It has to be either mania or depression. And what this could look like is 4 depressive episodes right in a row, like you have depression for 6 weeks and then you recover, and then you have another episode of depression for 6 weeks, and then you recover. If you do that 4 times in a year, that would be considered rapid cycling. Or the opposite if you were having manic episodes, or if you were having a manic episode and then a depressive episode and then a depressive episode and then a manic episode, that would be rapid cycling. So rapid cycling occurs in 10 to 20% of people with bipolar disorder, and women and people with bipolar 2 disorder are more likely to experience periods of rapid cycling. Now, this is kind of interesting because this totally contradicts what I just said, which is that people with hypomanic episodes are generally not considered as part of rapid cycling. So I found some contradictory information in the literature, and that's why I wanted to present both of these facts to you, is that the first fact is that hypomanic episodes do not count as part of rapid cycling. But the second point of view is that people with bipolar 2 disorder who naturally only have, not only, but who have hypomanic episodes but not manic episodes are more likely to experience periods of rapid cycling. I have another video. This is my favorite YouTube psychologist. Then she's talking about ultraradian cycling, and she'll talk to you in more detail about what this is. But basically, what ultraradian cycling is even faster than 4 episodes a year. So ultraradian cycling can look like having a manic episode and a depressive episode in 1 or 2 days, like you're manic one day and you're depressed the next day, or maybe even some people call it ultraradian cycling, where you have a manic episode and a depressive episode in the same day or even in the same hour. Some experts suppose that ultraradian cycling only occurs in people who also have borderline personality disorder, especially that ultra rapid thing I was just talking about, where you're going to have mania and depression in 1 day. So she's going to talk about ultraradian cycling, and I think it's important to give attention to ultraradian cycling because a lot of times when people think about rapid cycling, this is what they're thinking of. They're thinking of, oh, I was depressed on Monday and I'm manic on Tuesday and I'm manic on Wednesday and I'm depressed on Thursday. And that's not what psychiatrists refer to as a rapid cycling, right? They refer to rapid cycling as having more than 4 episodes, and by episodes we're meaning 1 or 2 weeks at a time, of either depression or mania. With ultraradian cycling, again, you're looking at maybe multiple episodes in 1 week or multiple episodes in 1 day. So Catherine, go ahead and play this.
Okay.
And I don't know if any of you have seen this psychologist before, but she's awesome. She'll put her name up, and I would definitely recommend going to her site.
Yeah, she is really cool.
She's
Okay.
my favorite YouTube psychologist.
What is rapid cycling bipolar disorder? Ultra rapid cycling and ultradian. That's what I'm going to be talking about today. I'm Dr. Tracy Marks, a psychiatrist, and I publish weekly videos on mental health education and self-improvement. If you don't want to miss a video, hit subscribe and the notification bell. This topic is based on several viewer questions. And for more on what bipolar disorder is, watch the video that I have in the corner and in the description on defining bipolar. But in general, bipolar disorder is a mood disorder where you have episodes of depression and mania. And each of those episodes lasts a certain amount of time, 2 weeks for depression, 1 week for mania, and 4 days for hypomania. Rapid cycling bipolar disorder is thought to happen in about 10 to 15% of people with bipolar disorder and tends to be more common with bipolar 2 than bipolar 1. Rapid cycling is a course specifier. It's not a separate diagnosis. Instead, it's a description added to the end of the diagnosis to further explain how often you have episodes. So the rapid cycling specifier is added if you have 4 or more episodes of either depression, mania, or hypomania in a year. And if this is the case, then your diagnosis would be bipolar 1 or 2 with rapid cycling. Ultra rapid cycling is not an official term in our diagnostic manual. It's a term that researchers have coined and use to give an even more detailed description of how the illness plays out. People will usually say ultra rapid cycling when a person has mood switches each month. And ultra rapid cycling, also called ultradian, is when a person has mood cycles lasting a day. We use the DSM-5 to define and diagnose illnesses. If the shortest episode that you can have, according to the DSM, is 4 days for hypomania, then how can someone cycle in a day and it really be considered ultradian? Well, that's why this isn't an official diagnostic distinction, and how it's used is still controversial. It's important to tell the difference between shifting emotions and shifting a complete mood state. Your mood is how you feel emotionally. Your mood state, such as depression or mania, refers to a group of symptoms that include your activity level, your sleep, your motivation, etc. With a depressed state, you tend to be slowed down in many ways. And with mania, you tend to be sped up in many ways. So with rapid cycling, you're going from sped up to slowed and back and forth. And that's not the same thing as switching from crying to laughing over the course of a day. This would be an emotional change only and not necessarily a mood state change. We would call that emotionally labile. And emotional lability is only one aspect of bipolar disorder. There's more to it than shifting your emotions all of the time. Emotional changes like that can happen with borderline personality disorder or even post-traumatic stress disorder. But let's say you do have ultra rapid cycling with true switching of mood states that occurs monthly. Why would this happen? There are things that can destabilize your bipolar disorder and make you have state switches more frequently. Some of these things are things like a disrupted circadian rhythm that you would see with a wacky sleep or eating schedule. An example of this would be nearly reversing your day-night schedule to where you're sleeping super late in the day and then hardly sleeping much during regular night hours. People with bipolar disorder are very sensitive to biologic rhythms, and getting off track with some of these basic routines can trigger a relapse of an episode or cause them to switch back and forth. Working night shifts can make this happen. Other causes are brain injuries. And by the way, this doesn't have to be the kind of head injury like a gunshot wound or falling from a roof and losing consciousness. The brain is very soft, like the consistency of room temperature butter, and your skull protects it, but it can still get knocked around, hit, you can have a concussion, and you can recover from this kind of head trauma, but you can still get mood changes. And you can even see this kind of brain injury with mood changes with a stroke. Substance use, even alcohol can cause switching. Other medical illnesses like thyroid dysfunction or multiple sclerosis, taking antidepressants. The jury's still out on the usefulness of antidepressants for bipolar disorder, but since some studies have shown that antidepressants can cause switching in some people, if you have rapid cycling symptoms, then you should avoid taking or using antidepressants. And it may be that the best treatment for you is a combination of mood stabilizers rather than one mood stabilizer alone. That's bipolar disorder with rapid cycling. I did a video comparing rapid mood shifting with borderline personality disorder and how it can look like bipolar disorder. In this case, I'm talking about shifting emotions, not complete shifting from a depressive episode to a manic episode. Share this video and spread the knowledge. Thanks for watching.
Thank you, Catherine. So what I like most about that video, I think what happens is every time we show the video, I lose you. What I like most about that video is that she talks about the difference between mood state shifting and actual like emotional switching. So I think that's really important to discern. Like I was talking about, she talked about how this is often occurring in borderline personality disorder, where you have shifting moods or shifting emotions, but not shifting mood states. So for example, if you are, one of the most famous books about borderline personality disorder is called I Love You, I Hate You, Don't Leave Me. And so that is an example of a shifting emotional state of I hate you, get away from me, you're awful, you're terrible, and then don't leave me, I love you so much, please come back to me, blah blah. So that's kind of like a shifting emotional state that wouldn't be considered rapid cycling, because it's not a full mood state, it's just an emotional episode that's occurring at a particular time. So how is rapid cycling diagnosed? And she basically described this. But few people with rapid cycling cycle between periods of hypomania, which we talked about, and major depressive disorder. But however, it's far more common to have repeated and distinct episodes of depression. And that's one reason why she said that it's more common in bipolar 2 disorder, because people with bipolar 2 disorder experience depression and hypomania, but they don't experience a full-on manic episode. If you were to experience a full-on manic episode, then you would be diagnosed with bipolar 1 disorder. Someone is diagnosed with bipolar disorder after they have a hypomanic or manic episode with either multiple additional episodes of either mania, hypomania, or depression. And again, like what she said and like what I said at the beginning of this presentation, rapid cycling in and of itself is not a diagnosis, but it's a core specifier that talks about how your bipolar has been acting over the last year. So how do you identify rapid cycling? Rapid cycling can be difficult to identify, especially because of what she was talking about with the difference between mood states and emotional situations. So you may think, oh, like, for example, I have a friend right now who's going through a lot of stress in his marriage, and his father is dying, and he's living with his mom, and there's just like a lot of emotions going on. And so he's having really shifting emotional states. He'll be like really angry and really upset one day, and really anxious and really crying the next day, and really manic and running around the next day. That is not rapid cycling. That is situational emotional changes. So they don't represent multiple separate and distinct episodes. So again, rapid cycling may seem to make the changing mood states of bipolar disorder more obvious, but because most people with rapid cycling disorder spend far more time depressed than manic or hypomanic, they're often misdiagnosed with unipolar depression. And this can be dangerous, as Dr. Tracy Marks noted. There's some controversy around this, but there is some evidence to support the fact that SSRIs or SNRIs can actually trigger manic or hypomanic episodes in people with bipolar disorder, which is why people with bipolar, especially people with bipolar disorder with rapid cycling, need to be very careful about taking antidepressant medication because it can trigger a mixed episode, rapid cycling, or a manic episode. And this is the last video for today. This is another lived experience video. Just like the last one, it talks, I kind of wanted to show you a professional viewpoint of the feature and then a lived experience. So Catherine, you can go ahead.
Okay.
Hey guys, it's Hannah. Rapid cycling and bipolar disorder. So the definition of it is 4 or more episodes, depressive, hypomanic, manic, that occur within a 12-month period. And why I really want to talk about this today is because I'm actually going through rapid cycling. I have had kind of a lot on my plate this year, relatively speaking, a lot of stress that has really triggered me into one of these episodes. And I'm curious to hear what rapid cycling looks like for you, because everybody has such a different experience, and I'm going to share mine. So for those of you who don't know, I'm actually a rapid cycler. So this is something that I have to prepare for every couple of years. And what it looks like for me as well, bipolar is already a roller coaster. And rapid cycling is basically that roller coaster goes 10 times faster. Every day is different, and I find myself in more hypomanic episodes than I actually do in depressive episodes, which is really exhausting. You feel everything and nothing at the same time. I'm really out of sync. I'm irritable, but I'm not explosive. But I'm definitely off my game. I'm out of routine. You know, usually I try to get up at 6 a.m. in the morning, work out, prepare for the day.
Catherine, I have to go. Can you
You go
handle
to
this?
bed at 4 a.m. and you only sleep 2 hours. That's really difficult to do. My eating habits are way off. I mean, I eat dinner, no joke, at like 10 p.m., 11 p.m. at night, because I lose track of time and I'm trying to distract my mind and keep myself busy. So I'm all over the place, like scattered. Managing rapid cycling, well, like I said, I prepare on the off season, because the fact is I live with bipolar 2 disorder, and this is inevitable. Of course, open communication with my doctors, and I kind of have to distract myself in a good way. And isolation at this time isn't the best thing for me, but it kind of is. And in my experience with rapid cycling, I do this through creativity. I am writing more than I've ever written, fiction, nonfiction, journaling. And also I have taken on a creative project to kind of focus my mind in a good way. I'm building a table, yeah, with vintage love letters. I know, stop. You're like, oh my God, that's the greatest idea ever. And I'm really excited for it. It's just kind of a healthy way to distract my mind. I do the best I can to manage it. And actually right now during this period of time, for everything that I have on my plate, I'm in control. But I'm very aware that in the future, these types of episodes might be way more severe. And I'm not going to beat myself down for going through one of these periods, because it is what it is. And a lot of people go through this because it's really difficult for me to explain to other people, like my friends, what rapid cycling is like. That's why this community is so important, so I can share with you guys and you can share with me. And also, please share this video so that other people can share their experience. I look forward to all those comments and maybe response videos, and I will see you next week. Bye.
Okay, so now I need to go back and share my screen. Not that one. Sorry, I can never remember how to. Can you see me, guys?
Nope.
No, you can't see me.
Oh wait, I can see you. I'm sorry.
Oh,
I can't see your screen though.
can't see my screen. Let me see how to get that back. Okay, okay, hold on. I got it. This is way more technically complicated than I'm used to. I think I'm going to use my PC from now on. I'm using an Apple today. Okay, so we're coming up to the end of this presentation. And at the end, I do want to talk about your guys' experience with rapid cycling or ultra radiant rapid cycling, which Dr. Tracy Marks talked about. So a few things she didn't mention is that an early age of onset is associated with a greater likelihood of rapid cycling, and episode frequency is a familial trait. So if you have bipolar in your family and you have people with ultra radiant or just regular rapid cycling bipolar disorder, you're more likely to have rapid cycling or ultra radiant rapid cycling in yourself. So there's this brain-derived neurotropic factor, BDNF. You're going to start hearing a lot more about this. And it's coming up, it's the newest cutting-edge research in bipolar disorder. And they found that BDNF is associated with rapid cycling, but not with bipolar disorder in general. So, for example, many of you I know have taken the GeneSight genetic test for psychotropic medications, or there's other genetic testings out there for psychotropic medications. And I know that one of the things that the GeneSight test is, that's the brand name of the test, test for BDNF specifically. And I think you have to pay extra for a BDNF test from GeneSight. But what GeneSight and other genetic testing companies will do is test to see if you have the BDNF factor in your genetics. And that determines not only what kind of bipolar disorder you may have, but also what kinds of medications may be best for you. So for most people with rapid cycling, it is transient. It doesn't last your entire life. So what we just saw in that lived experience video is that the woman said, I have to deal with this every couple of years. So she's not dealing with it every year. Every year she doesn't rapid cycling, but every couple of years she may experience rapid cycling. So rapid cycling, and I had the last thing, and certainly ultra radiant rapid cycling basically sucks on all levels. So the treatments for mixed episodes in rapid cycling, they're treated the same way as mania is, with either atypical antipsychotics and mood stabilizers. So the big mood stabilizers are lithium, and then all of the anti-seizure medications, Lamictal, Depakote, Trileptal, Tegretol. Those are the big mood stabilizers. And most people are going to be on either an atypical antipsychotic and or one of these mood stabilizers, either lithium or one of the anti-seizure meds, to manage mixed episodes in rapid cycling. And if the dominant mood in your mixed episode is depressive, an antidepressant may be added. But again, like what we saw in these videos, it should really be done only under intense supervision, because it can increase the risk of suicide in mixed episodes. So again, what we saw in these videos is that if you take an SSRI or an SNRI and add it to someone who is depressed, if they have an underlying bipolar trait or underlying mixed episode or underlying rapid cycling trait, it can actually trigger that mixed episode and can increase the risk of suicide. So the FDA approved methods for treating ultra radiant cycling are lithium, which again is the primary mood stabilizer that we see for most people with bipolar disorder, Seroquel, which is an atypical antipsychotic, and Latuda and Zyprexa, which are also atypical antipsychotic. Now, your psychiatrist may prescribe something else for ultra radiant rapid cycling, and a lot of medications are used off-label for other purposes. So, for example, Latuda and Latuda especially is used often as a mood stabilizer along as an antipsychotic. So you're going to see different ways that your doctor uses this. And if you have questions about your medications, always ask your psychiatrist or your medication prescriber about why they've chosen to put you on certain medications and what they do and what their side effects are and how they interact with your other drugs that you're taking. And the last, my last slide here talks about antidepressants again, which Prozac and Zoloft specifically have not been shown to treat the depressive symptoms of rapid cycling and may even increase the frequency of new episodes over time. So many experts advise against the use of especially long-term antidepressants in bipolar patients with rapid cycling. And then we talked about the mood stabilizing drugs, which are the lithium plus the anti-seizure meds, such as Tegretol, Depakote, Lamictal, and Trileptal. They're the core treatments of rapid cycling, as well as the core treatments for bipolar disorder in terms of a mood stabilizer. Some antipsychotic medications, such as Zyprexa and Seroquel, have also been studied in rapid cycling and are used as part of the treatment, whether or not you have psychosis. So that's important to note, that you may be on an antipsychotic medication like Seroquel or Latuda and think, why the hell am I on an antipsychotic? I've never had psychosis. And what they found is that a lot of these antipsychotic medications actually work as mood stabilizers. I know for a fact that Invega and Abilify and Latuda, those are three that come to mind, are used as mood stabilizers as well as antipsychotics. So that's all I have for you today. If you want to use the chat box for any questions or raise your hand and talk, any discussion. And I can't see the chat box, so Catherine, if you can manage that.
I got it. Any questions? No one? What about Symbiax for rapid cycling? Have you heard of that?
What did you say?
Symbiax? Symbiax?
Symbiax?
Yeah, I've never heard of that.
Where does it say Symbiac? Did I spell something wrong?
No. Someone asked about that.
Symbiac. I've never heard of that. What is it?
Prozac and Zyprexa together.
Oh,
That sounds like
it might be okay. So Prozac is specifically, and Paxil and Zoloft are specifically shown to increase rapid cycling. But if you were to combine it with Zyprexa, that's very possible that it would prevent that SSRI, such as Prozac, Paxil, and Zoloft. It would prevent that SSRI from triggering a manic or a rapid cycling episode.
more questions.
I mean, generally speaking, if you are on any sort of antidepressant and you have bipolar disorder, you should definitely be on either an antipsychotic, which has mood stabilizing properties, or one of the traditional mood stabilizing drugs. This is lithium and the anti-seizure medications.
All right, I got another question. Did you say rapid cycling could be a period of hypomania, a return to baseline, and then return to hypomania again?
Yes.
Okay.
And that's most often seen in bipolar 2 disorder. But I personally, as someone with schizoaffective, my rapid cycling, or when I have rapid cycling, looks like multiple episodes of, or a prolonged episode of a hypomania mixed with a manic episode. And then sometimes I'll get a mixed episode in there as well. Any other questions?
Do we know anything about corticosteroid-induced bipolar disorder, and if it has any association with rapid cycling? Corticosteroid.
That's a really good question. Corticosteroids can definitely cause mood episodes such as mania and mixed episodes. However, corticosteroid, like prednisone, is a corticosteroid. Corticosteroids can cause mood episodes, especially like anxiety and agitation, and irritability and anger episodes, or things that look a lot like hypomania or mania. However, corticosteroid, to the best of my knowledge, corticosteroid induced mood episodes are not considered bipolar disorder. if you have a corticosteroid mood episode, let's say you don't have bipolar and you're given prednisone and you get really angry and raging and you run through the house and then you're really manic and really goal oriented. And then as soon as you go off the prednisone, you go back down to baseline. That's not considered bipolar disorder. That's basically a side effect of the prednisone. So I'm not aware of any research that says that corticosteroids like prednisone actually cause bipolar disorder. They can just cause mood episodes that kind of look like bipolar disorder. Now, if you were to have a corticosteroid treatment such as prednisone, and then the mood episode continued after the discontinuation of the steroid, then it is possible that you would be diagnosed with bipolar disorder, but I don't think your doctor would say that the prednisone itself or the steroid itself triggered the bipolar disorder, more that you just had bipolar disorder and the corticosteroid kind of let that come to life, if that makes sense.
Someone said their mom is on Cortef and has been rapid cycling ever since starting 25 years ago.
She's on Cordis for 25 years.
I guess,
And
yeah.
that's a corticosteroid, right?
Cortisol replacement.
Yeah, so that, I'm not a medical doctor, so I can't really comment on that for sure. But if you're on a corticosteroid for 25 years and you have rapid cycling, I would say that is probably a side effect of the steroid and not true bipolar disorder. But again, I'm not a medical doctor, so I can't really comment. Maybe, Catherine, you should get one of the guest speakers to come on to talk about either rapid cycling and steroid use, because corticosteroids can really cause havoc with your moods. And it can really look like bipolar disorder, especially if someone is on something for 25 years.
Yeah, that would be a good idea. Any more questions? Okay, can I go off topic really quickly?
Yeah.
Since I have you guys here, does anyone have any suggestions for topics for guest speakers? Off the top of your head? Because I'm looking for some now.
I posted an article, Catherine, I think last week, and I asked for your feedback about whether or not you thought that article would make a good guest speaker. Do you remember seeing that?
I didn't, but I will check it out.
Go back and look at it. I don't remember what it was about, but it was a recent article that came out, I think in 2021. And it looked like it would really be a good fit for the group as far as a guest speaker.
Okay, wonderful. I'll check it out. Anyone have any questions? Anything to add? How to gain insight when manic, hypomanic for those who have trouble recognizing that they're in an episode during an episode.
That's a really good question. If you live with somebody or have close friends that you talk to on a regular basis, having this discussion with your close friends or your living partners to say, this is what it looks like when I'm hypomanic or manic or depressed and I don't always recognize it. Having that kind of close friend network is really important with bipolar disorder, as well as schizoaffective disorder. And having other people saying to you, hey, you seem like you're kind of racing, or you seem like you're a little hypomanic. What do you think about that? And of course, the problem with that is if you are hypomanic or manic, that's going to make you bristle a little and say, hey, get away from me. I'm not manic. Which may be a sign that you are. So that's what I found for myself, is having my close friends and my living partners talk to me on an honest and open way about what they notice about my behavior. However, if you live alone or you don't have a close friendship network, having a good therapist and having a good psychiatrist or med provider who can point out your mood changes to you would be really helpful, especially if you have weekly therapy, which I highly recommend for everyone that can access it. Having weekly therapy, that person's going to see you every week. They're going to notice mood changes and they can point out those mood changes to you if you're not able to notice them in yourself.
I'm reading a lot into nutritional psychology and psychobiotics. Uma Nadoy's book was awesome.
Uma Nadoy?
I've never heard of that person.
I'm going to write down UMA, and what's her last name?
Naidoo.
Okay, yeah, I'll look her up. I've heard a bit about gut science.
Mhm.
And how gut microbes and the microbiome in your gut can influence your mood, but I don't know enough about to speak about it, but it's very interesting science.
Her book is called This Is Your Brain on Food.
This is your brain on food. Okay, cool, thanks.
Any more
Anything else?
questions? How does the MTHFR gene play a role in bipolar and rapid cycling?
Unfortunately, I do not know. I've heard a bit about it, just like I've heard a bit about the BDNF gene. I know that the MTHR gene is important in bipolar disorder, but again, I'm not a medical doctor or a geneticist. So unfortunately, I don't know a lot about it. And I can't really point you to any good references. However, you might check out the GeneSight website. Again, it's a commercial website, so they are trying to sell you a product, but they have some information about both of those gene types there. And so you may be able to read more about either on GeneSight or other genetic testing websites.
Shall we wrap it up?
I have no more questions. Thank you for listening to me.
Thank
Have
you,
any other
guys.
questions? And
Thank
I will
That was
continue to post.
informative.
What?
Thank you. That was very informative.
Oh, I'm
Yeah.
glad you liked it.
I
Thank you.
appreciate it. I learned a lot, actually.
Yeah.
Thank
Awesome.
you.
Cool, thank you.
Thanks.
And I'll continue posting weekly. And I think Catherine and I have a couple of presentations coming up in the next couple of months. One about how to read scientific articles, and one about an article that she and I co-authored in bipolar disorders. So we'll be talking about both those things coming up.
Okay, good.
Thank
Bye,
you.
guys.
Do that. Thank
Bye,
you.
everyone.
Bye,
Bye-bye.
Kate.
Bye. Bye.
Bye.
Bye. Thank you.
Thank you.